Colligo-HCM data actually strongly mirrors our experience in the inherited practice at UAB. Once we start myosin inhibition using Mavacamten, patients often achieve rapid relief, both in terms of gradient reduction and symptom improvement. For example, in Colligo, nearly 90% of patients reach the resting LVOT gradients less than 30 millimeter by week 36, and 77% did after the Valsalva, the provoked gradients. 60% improve at least one NYHA class by week 24. These benefits were durable throughout up until week 96. And that is exactly the trajectory we are seeing clinically: rapid, sustained improvement in patients' functional status and quality of life. Yeah, that is a great question. Colligo-HCM is a unique effort in the sense that it represents the most ethnically and geographically diverse population ever studied for Mavacamten. For example, there were 23% of patients in the registry, those were Blacks, compared to, let's say, the large trials such as Explorer-HCM, where 1% of Black population was recruited. And nearly a third of patients in the monotherapy group were Black. So if you think in the subgroup, the Black population had higher rates of hypertension, which may reflect a more comorbid real-world population. So yet the outcomes we noticed were very consistent across groups, which reinforces that Mavacamten is not only effective but equitable. And I think the study per se helps close a major representation gap in HCM research. I think the lower gradients and the improved NYHA class, as I mentioned earlier, these are not just endpoints, they are really life-changing. When you think in Colligo, 94% of patients were NYHA class 2 or better by week 24, and nearly a third reached class 1. When you think of it clinically, this translates into the ability to climb stairs, return to work, re-engage in daily life without fear of breathlessness or pre-syncope or syncope. The relief is not just clinical, it is deeply personal for some of these patients. This is an important point. In Colligo, 26% of patients discontinued at least one background medication, and 7% roughly were started on Mavacamten monotherapy. We also saw a subgroup who down-titrated therapy. So for many patients, reducing reliance on beta blockers or calcium channel blockers, which are in the guidelines as class 1 agents, improves their tolerability and exercise capacity. These data suggest that Mavacamten monotherapy isn't just effective, but it will also help simplify care, reduce treatment burden, and enhance long-term adherence. I think with dual endorsement that we have both from the ESC and AHA, ACC guidelines, myosin inhibition in obstructive HCM, myosin inhibition using Mavacamten is now firmly established in the treatment algorithm, so to speak. We are seeing earlier conversations about initiating the myosin inhibition, especially in patients with persistent symptoms, despite some of the first line agents that we discussed. Many of our patient population, they do not want to go for septal reduction therapies because of the comorbidity burden associated with those procedures. So the data support has now sort of evolved, showing real-world effectiveness, and it can be used as a monotherapy. I think it's no longer just an alternative, it is becoming foundational to how we treat symptomatic obstructive HCM.